So then we're going to work through the rest of the knee. We go into the intercondylar notch, and that's the ligamentum mucosum I'm getting rid of. There's a torn ACL. So that's prolapse backwards, prolapse forwards towards the fat pad, just getting rid of a little bit of that so I can get into the lateral compartment nice and easily. But there you can see the top end of the ACL is detached from the femur. That's pointing to the posterior cruciate ligament. There's a bit of fat overlying that. And now we're going to change the position of the knee so I can look into the lateral compartment, adjust my camera so people don't get seasick, lateral femoral condyle, lateral tibial plateau, lateral meniscus in between. And it doesn't project very well, but there were very tiny superficial tears on the superior and inferior surfaces. That's looking at the posterior root of the lateral meniscus, and now we're looking where the ACL has been torn away from the femur. And that'll be where we concentrate later on when we're drilling the femoral tunnel.
So do you have like a systematic approach when you go in for the arthroscope component to it? Is it essentially like a pilot and you've just got your checklist that you're going to go through in a routine order?
Absolutely, and that's super important. It's very easy to forget stuff. It's amazing. You'd think you do thousands of these things and it's all routine, but you do have to have that checklist. So I've got my order. Someone else might have a different order. It's very important you do have a set order. It is easy to forget something when you've progressed further. But for me, I start looking at the patellofemoral compartment. I look at the patella, then the trochlea, superiorly, inferiorly. Then I go to the lateral side of the knee, then medial side, and work my way across. If, for instance, in that particular example, I decided I was going to repair the medial meniscus, I wouldn't do anything just then. This patient was having a hamstring graft, so I have to harvest the hamstring. And when we repair the meniscus, well, when I repair a meniscus, I use sutures that go from inside to out. There's different ways of repairing, and we might talk about that later. But though that means there's needles going through the medial side of the knee that could potentially pass through the hamstring tendons. And so if I repair the meniscus first and then go to harvest my hamstring tendon, I'm going to cut through my meniscal sutures. These are lessons learned over 33 years of private practice or whatever it is. But so, yeah, that's why it's so important to have your routine. But I like to do the arthroscopy, get all the arthroscopic work that can be done out of the way so I don't forget it later on when I'm concentrating on the ACL.
That was going to be, your part answered my next question, which was what do you do, like procedure-wise, treatment-wise, during that arthroscope, and what do you park until later? You mentioned that you'll do the suturing of a meniscus repair, obviously the harvesting of the graft, the ACL reconstruction itself, assuming obviously also like any extra articular procedures.
Yeah.
That one was a meniscectomy. What about if someone had like a chondral defect, or if you're looking at something like a posterolateral corner laxity? I mean, when do you address those?
Okay. So pretty much everything gets done then except a medial meniscal repair that involves suturing. You can repair with so-called all-inside devices where you don't actually go much beyond the capsule with the device, and that doesn't interfere with hamstring harvest. If I was repairing the medial meniscus in that particular instance and I was doing a hamstring graft, I would harvest the hamstring next. If I was using a quadriceps tendon graft, what I would actually do is make my incision posteromedially for retrieving the sutures that I'm going to put in. Mm-hmm. I would then go back and put all my sutures in, finish that. I like to have as much of the arthroscopic work completed before I go on to the next stage. If it was a quads tendon graft, as I say, I can do that later, finished inside the knee. With regard to chondral surgery, all that's done before I progress. If there's something on the lateral side that needs extra articular surgery, so a posterolateral corner repair, for instance, that's going to happen later. Mm-hmm. A lateral meniscal repair I would do there and then, so that's dealt with. I might modify the incision I use for that if I'm doing a lateral tenodesis. There's lots of bits to think about, but in principle, arthroscopy, harvest the graft, drill the tunnels, put the graft in place. Don't fix it at the tibial side. Go to the lateral side. If I'm doing a lateral tenodesis, do that, and then fix the graft.
Right.
And there's a specific reason for that. And people who've listened to these sessions before know I'm obsessed about regaining knee extension.
Mm-hmm.
And I don't want to be the one to blame for that. So I know that knee fully extends at the end of the operation. There's nothing mechanically blocking it. I do worry a little bit about lateral tenodesis and the impact it has on extension, and we'll talk about that further. But I do my lateral tenodesis before I fix the graft, so I can take the knee into full extension and then fix the graft. And that way I know that I haven't sort of over-tightened the graft, so to speak. So that mechanically it's not going to be the problem. It's more a pain type issue.
My last question, just about the arthroscopy component of it, is that those both the porthole site and also the operating window is very close to the fat pad. There's a physio like the fat pad. We often kind of get it, and it's quite angry.
Yep.
And it's like, why? Is it a surgical technique thing that someone who's experienced like you will kind of be able to manoeuvre around that fat pad and make it not so angry as others, or is it potluck?
I don't know about potluck. I think it's interesting because physios do have a lot to do with fat pads and talk about the fat pad. And I've just come from a clinic this morning where I saw quite a few post-op patients, and the patients are telling me they've got this fat pad swelling, and that's obviously come from the physio. And the portals themselves will be swollen because they're cuts going into the knee, they bleed, and they have to heal. So there'll be local swelling around the portals. That's not in itself fat pad swelling. Between the two portals, as you say, is the fat pad. In that arthroscopy, I said it fairly quickly, but I resected the ligamentum mucosum, which extends from the fat pad up to the apex of the intercondylar notch, but it gets mistaken for the ACL, unfortunately, sometimes, but you need to remove that, and then that floats towards the front of the knee. Mm-hmm. But still, in a knee that's a bit irritated, the fat pad will tend to get in the way a bit. Sometimes people have more fat than others, obviously, and, if you've got more fat outside, you'll have more fat inside. So sometimes we have to shave some of the fat pad away so we can see what we're doing. Some people will never touch the fat pad. They believe it should not be touched. I want to see what I'm doing, number one. And so I guess that's just a philosophical thing. I do tend to put tranexamic acid into the knee quite often, which reduces the bleeding a little bit, but we don't want to reduce it too much because blood's good. Blood's got good things in it for healing. Yeah. But it is a problem, the fat pad. And when I make the anteromedial portal for an arthroscopy alone compared to an ACL reconstruction, I can stay a little bit further away from the fat pad, but I have to stay really close or even go through the medial border of the fat pad for an ACL reconstruction in terms of lining our tunnel up or guide wire to create the femoral tunnel. And that means we have to resect some. And I think people who just put their portal in the same places for routine arthroscopy will avoid the fat pad, which is great, but run the risk of either putting their femoral tunnel in the wrong spot or damaging the articular surface as they're drilling.
Okay, understood. Good comments.
So now we're looking at routine hamstring harvest. And I've made my incision. I use an oblique incision. That's entirely surgeon preference. And then we have to expose the fascia, which is the sartorius fascia, the pes serenus, say grace before tea, so sartorius fascia overlying the gracilis and the semitendinosus tendons. I'm making a split into that fascia, which releases a vacuum. And now I'm going to expose the gracilis tendon. I use a hook to pick up the tendon, and then we'll lever on that, and this is where it starts to become clear as to why things hurt sometimes after surgery. So there's the gracilis tendon. To harvest it, we use this tendon stripper, and that gets slid up into the thigh, and out comes what isn't quite a short gracilis tendon, but you can only work with what you've got. So we pull on gracilis, and that will then bring semitendinosus into view. Same deal. Lean on it. Semitendinosus has these little slips called vincula, and so I'm just going in there to cut those vinculae. If I don't cut them, I can accidentally amputate the tendon short. So same procedure, lever on the tendon, make sure it's free, protect the skin with the pack, get my tendon stripper out. There are different sorts of tendon strippers. This is the type I use, open-ended. push, and out comes the semitendinosus tendon with a bit of muscle. So this idea that you might be preserving some of the tendon is completely false. That tendon's outside, the muscle's belly, you can see a little bit of the distal part of the muscle belly, but the bulk of the muscle belly has retracted and will eventually attach to the adjacent muscle bellies. But you have to lose some strength because your semitendinosus has been significantly defunctioned. Gracilis doesn't really contribute any significant strength anyway.